Hello, I'm Annette Kelsen. I'm professor in rhinology and vascular malformations at Odense University Hospital. The title of my talk today is Hereditary Hemorrhagic Telangiectasia, abbreviated as HHT. This is more than a bleeding nose. What an ENT doctor needs to know about HHT and why. HHT is a rare vascular disease. It's hereditary, autosomal dominantly inherited, and there are three well-characterized subtypes. It's hemorrhagic with epistaxis or bleeding from oral mucosa, GI tract, skin, or arteriovenous malformations. And then there are the telangiectatic lesions, which are dilatations of the vessels, the postcapillary venules, which may enlarge to arteriovenous malformations. The disease is rare. However, population studies have shown that 1 in 6,400 persons has HHT. We all know the epistaxis patient, but when should HHT be considered? HHT should be considered if the patient has recurrent episodes of epistaxis. The epistaxis episode starts normally in a young age, but may start at all ages, as shown in this figure of 318 Danish HHT patients. HHT should be considered if telangiectatic lesions are present. You should look for these at the fingertips, at the skin of the face and around the mouth, in the oral mucosa, and of course in the nasal mucosa. HHT should be considered if there is a family history of other HHT manifestations, as for example family history of nosebleeds. So always ask your patients of their family history. HHT should also be considered if the patient has had cerebral abscess or cerebral infarction. These are signs of PAVM, which are very common among HHT patients. Around 1/3 of HHT patients has PAVM. These may cause paradoxical embolization, migraine, hypoxemia, and clubbing of the fingernails. This leads us to the diagnostic criteria of HHT, the Kurosawa criteria. They consist of 4 criteria. 3 or 4 are present if definite HHT, while 2 criteria present is possible HHT, and 1 criteria is unlikely HHT. The criteria are nosebleeds, which should be spontaneous and recurrent bleedings, telangiectatic lesions, multiple on special locations, lips, oral cavity, fingertips and nasal mucosa, visceral lesions, gastrointestinal, pulmonary, liver, brain or spine, and family history, 1 first-degree relative with HHT. So, what is the role of the ENT doctor in diagnosing HHT? Well, ENT doctors are often the first doctors the patients consult, and ENT doctors have the expertise in diagnosing the nasal mucosa. So, ENT doctors can prevent severe morbidity by referring HHT patients for screening and treatment. HHT is a vascular disease, so HHT clinical manifestations may occur in all parts of the body. It causes epistaxis with anemia and social disability. It causes telangiectatic lesions in the skin, for example in the fingertips or in the skin of the face, and these may cause bleeding, cosmetic concern, and pain. Telangiectatic lesions in the GI tract may cause bleeding and anemia. Arteriovenous malformations may occur in the liver. Here they cause shunting and pain. Arteriovenous malformations may occur in the brain as cerebral arteriovenous malformation. They may cause bleeding and epilepsy, and as already described, pulmonary arteriovenous malformations may cause hypoxemia, polycythemia, migraine, paradoxical embolization as cerebral abscess or apoplexia, and in some rare cases even bleeding. And these patients carry a serious risk of having, for example, a cerebral abscess. We have looked into the Danish population of HHT patients with macroscopic PAVM, and we found that 8% of them had a history of cerebral abscess before they were referred to the HHT center. This is 400 times the risk of the normal background population. We have looked into the survival of the HHT patients in the Danish HHT center during the last 20 years when the center has been working, and we have treated the patients for PAVM and for bleeding episodes. And during this period, we compared the HHT patients with 218 controls. In the beginning, there was a tendency toward higher mortality among the HHT patients, but during the observed period, we found that the patients had the same survival as the controls. This may be a consequence of the treatment the patients received at the HHT center. Patients live with HHT, and they may live long if diagnosed and treated. We can help them by taking care of pulmonary AVM, anemia, epistaxis, GI bleeding, and other clinical manifestations. Just to summarize, HHT should be considered if the patient has recurrent episodes of epistaxis, if telangiectatic lesions are present, if there is a family history of nosebleeds, and if the patient has cerebral abscess or cerebral infarction.